pediatric trauma. So, children, as distinguished from adults, tend to have, yeah, thanks for sending that, Andrew, tends to have specific injury patterns, and their physiological response to trauma is unique as well. So head trauma, for example, is a major cause of death, and compared to adults, they have proportionally larger heads, thinner skulls, and poor muscle control. One of the things I discovered, I can't remember if I mentioned this to you before, but when I spent some time in the cadaver lab at the, not the cadaver lab, sorry, the office of the chief coroner's office, they did an autopsy on a guy in his teens, and they showed me the duramater and showed how it peeled away easily from the inner table of the skull. And then we did an autopsy later on a guy in his 80s, and the duramater was attached to the inner table of the skull, almost like Velcro. It was really, really difficult to peel away. And he was saying that for that reason, kids and adults will have epidural hematomas and can die from them fairly quickly, whereas the elderly patients are far less likely to die, within the first 6 hours or so from an epidural hematoma, in contrast, because the duramater is attached so tightly to the inner table of the skull. I just thought that was interesting. So with kids, diffuse cerebral edema is more common than intracranial hematomas, and some of the common hematomas that we do see in kids, though, are subdurals and epidurals and intracerebral hemorrhage. So monitoring for signs of increased intracranial pressure includes looking at your primary survey at their APCT2 and signs of confusion, altered or depressed LOC, pupil changes, vomiting, Cushing's triad, which is hypertension, bradycardia, and widening pulse pressure. That's a late sign. And in terms of management for head trauma, we're going to secure the airway if the GCS is 8 or less on a PRN basis. And what's the formula for ETT size in kids?
Four plus 4.
Sorry, say it again. The first part was cut off.
Age over 4 plus 4.
Yeah, thank you. And BPV as per BLS standards, monitor end-tidal CO2, resuscitate hypovolemic shock aggressively. Now, when I say that, what I mean specifically is that hypovolemia in head injury is actually worse for outcome than hypoxia in head injury. So whether it's adult or child, if they're hypovolemic, they should be fluid resuscitated aggressively. So don't worry about 20 cc per kilo bolus or even 30 or 40 cc's per kilo bolus if it's clearly indicated. Now, obviously, you're going to patch for anything beyond 20 cc's per kilo, but we want to manage hypovolemia aggressively to maintain cerebral perfusion pressures. Shaken baby, there's about 40 cases a year that are reported in Canada, and about almost 30% will die, so the mortality rate is really, really high, and about half of them will survive with long-term neurological sequela. MJ?
When it comes to the term aggressive fluid resuscitation, are you referring to multiple lines? Are you referring to just simply leaving the line wide open, or pressure infuser? What do you mean?
Yeah, so we're talking 20 cc's per kilo in at a fast rate. So if you can do it under pressure, great. If you can do it as a constant flow, great. Do you need 2 IVs? Probably not. It's not a real priority, just a single line, large bore if you can get it. And if it's running wide open and it's flowing like not a drip but a constant flow, you probably don't need a pressure bag. But if it's not a constant flow, you probably need a pressure bag. So yeah, so we're talking about 20 cc's per kilo over 10 to 15 minutes.
Okay.
Yeah. One of the sequelae from shaking baby includes blindness, hearing loss, learning disabilities, seizures, spasticity, coma. So, in terms of assessment, any unexplained altered LOC should raise your index of suspicion. This may be a shaking baby case. Altered pupil responses, neurogenic shocks, so loss of reflexes, loss of thermal control, so hypo or hyperthermia. And in the ER, what they look for are bilateral retinal hemorrhages. So some warning signs include unexplained altered LOC, unexplained sleepiness or inability to wake the child, changes in speech, crawling, walking, signs of increased ICP, including irritability, high-pitched cry, pupils are sluggish, progressive to unresponsiveness, feeding changes. And unfortunately, a lot of these symptoms are vague to begin with, right? So feeding changes could be any one of a number of things, but other things include changes in gag reflex, swallow, gasp, suck, and there may or may not be any physical signs of injuries accompanied with that, other than retinal hemorrhage that they'll, assess in hospital. Spinal trauma, a number of different mechanisms, usually occur at C1 through C3, so more typically high C-spine in kids, and dislocations are more common than fractures in kids. One of the things that's I find unfortunate about being a paramedic, some of you have kids. Being a paramedic, I think, is, unfortunately, I've seen some of the most bizarre and some of the worst injuries imaginable in kids and adults, and it makes you just a little bit paranoid when I think about how paranoid I am, and I try really, really hard not to be an overprotective parent, although it might be too late at this stage. But I think about a time when we got a night table for my daughter, and I said to my wife, "This needs to be flush against the bed." She said, "Well, it doesn't look right flush against the bed. It should be like a foot out or so." And all I could think of was these two kids, these two 6-year-olds who were wrestling on this bed, and one of them fell off and got his head wedged between the bed and the night table, and his body twisted while his head remains steady, and he subluxated his C-spine. He ended up with just some partial paralysis on one side, but what's the incidence of that kind of injury? Extremely rare, like 1 in a billion, right? But it's forever corrupted me as a dad. So suspected trauma, we should suspect trauma for sudden decelerations, motor vehicle collisions, falls, head injuries. We should suspect C-spine injuries. Decreased LOC, again, we can't rule out C-spine with decreased LOC, and so we want to assess and manage ABCs carefully. In terms of thoracic trauma, so the thorax is pretty pliable. We had this years ago when I worked at Ariamis. We did a call up in Apsley near Peterborough for a child. I think he was a 3-year-old, I want to say. And Mom, the kid, and Granddad stopped at the gas station. Mom went in to buy something in the gas station and asked Granddad to look after the kid. So he was watching the kid, and then he lost sight of them and thought the kid was with Mom. And he went to back up his car and backed the car right up over the kid. And we just happened to be flying in the area, and we landed right near the gas station and picked up this kid. And he was struggling to breathe, and he had the rear tire of the vehicle went right over his back, and he had contusions the shape of tire tracks on his back. And we were providing a little bit of PPV for him on the way to Sick Kids Hospital, and he made a full recovery. It was quite remarkable. He had no rib fractures, he had no intra-abdominal injuries, no intrathoracic injuries, and and the granddad, from what I heard, had a complete and utter mental breakdown after that incident. So I feel somewhat badly for him, but kids just You know, I can't be critical of Granddad because things just happen with kids. It's remarkable. Listen, I can tell you worse babysitting stories, and I'm sure you guys can too. So that wouldn't be too judgmental. Chest trauma is the second most common cause of deaths in trauma, and 90% of deaths are blunt trauma, at least in Canada anyway. Kids have a pretty mobile mediastinum, and they don't do well with the tension pneumothorax. They get compression in their vena cava quite easily, and they also have a limited respiratory reserve and poor chest injury tolerance. So you have to think about needle thoracostomy with those kids early. Abdominal trauma is the most common pediatric trauma, not the most common cause of bleeding death. It's usually blunt, and the liver and spleen are injured more often than adults, and they're injured more often because as a child grows, the liver and spleen are more exposed beneath the ribs. The rib cage doesn't grow quite at the same pace as the rest of the body, presumably, and so the liver and spleen end up somewhat exposed. They have these high, broad costal arches, relatively larger organs, weak abdominal wall, and splenic injury between the two is the more common. And so any sort of tenderness in the left or right upper quadrant for that matter, but especially with deep breaths, would suggest a splenic injury or liver injury on the right hand side until proven otherwise. So that's what an adult looks like. The liver is somewhat exposed, the spleen quite well protected under the rib cage. With a pediatric patient, let me just go back to the slide. You can see the spleen comes further down and is much more exposed in kids. So abdominal trauma, first principles, tenderness means that they've got significant underlying injury until proven otherwise. And distension means the same thing, significant trauma until proven otherwise, distension of the abdomen, that is. Extremity trauma, obviously never severe enough to warrant attention before we look after ABCs, head, chest, and abdominal injuries. And because their bones are so pliant, they absorb and dissipate significant force. And green stick fractures in extremities are more common in kids for that reason. And so any painful, tender, guarded extremity is treated as a fracture until proven otherwise, because there may not be any bony crepitus, there may not be any obvious signs of deformity or of a fracture, but if it's tender, and we treat it like a fracture anyway. This is Waddell's fracture, or Waddell's triad, which you're probably familiar with. So kids about the age of 8 or less, or 10 or less, are when they're hit by a car, are the types of injury patterns we often see are femur or pelvic fractures, abdominal and thoracic injury, and head injury as they get thrown and strike their head on the way down to the ground, or not on the way down, but once they hit the ground. Burns in children, children account for about 50% of burn admissions, 33% of burn deaths, and large body surface area increases fluid loss, heat loss. Smaller airways means increased risk of airway obstruction, excuse me. Always consider the possibility of child abuse if the story doesn't match the burn pattern. If there's sort of stocking or glove injuries from forced immersion of a hand or a foot into hot water, and or unusually deep burns. In terms of assessment of pediatric patients, we've got AVPU, so if they're alert, their GCS is probably between 13 and 15. If they're responsive, verbal only, then they're about 12. Pain would be 8 or less, and unresponsive obviously would be a 3. And then there's modified Glasgow Coma scores for kids. In terms of testing, I don't expect anyone to memorize these modified GCSs for infants under 1 year or 1 to 4 years. But it's good to carry a flashcard like this in your on your smartphone, just as a reference when you're dealing with kids. Any of you carry one of these, by the way? I have one in my photo collection. Oh yeah, that's right. It's on the OBHD app. I've forgotten about that. Good. So in terms of assessments, we want to take injuries a little bit more seriously in kids, paying close attention to their airway, and we avoid inspection of the airway with things like croup and epiglottitis, just because it's agitating to the kid. And for cardiac arrest, it's the same approach as adults. It's CAD, vital signs, and just be aware that vital signs tend to be will hold steady until they suddenly plummet. I don't know if I said this to you before, but I'm not a fan of the word stable. I would never describe anyone's vital signs as stable unless I had access to their vital signs from the last 24 hours. You might say their vital signs are within normal limits or they're unremarkable, but to say they're stable based on 1 or 2 sets of vitals is really not a safe assumption. And focused exam, SpO2, ECG. This pain scale for kids is probably helpful in the absence of them being able to tell you what their pain is on a 1 to 10 scale. And generally, kids can't give you a pain scale until they're, close to 12 years of age, typically. In terms of management, care is going to be largely supportive, ensuring a patent airway, and any slight hint of an airway problem is serious until proven otherwise, as I mentioned. High FiO2s, PBD, hypoxia, again, remember, is a more common cause of morbidity and mortality in children compared with adults. And we want to manage ventilation through basic means, PPD. And rarely do we intubate kids, and in fact, Charles, I know you got the opportunity to intubate one pediatric patient. Has anyone had the opportunity to intubate a neonate? Okay, we'll say no. And I'm going to guess probably you may never get the opportunity to intubate a neonate. So dummies might be helpful for sure, or patient simulators, but they're not going to prepare you adequately for intubating infants and neonates and pediatric patients. So what I would suggest is that if you can manage airway and positive pressure ventilation with basic means, that's probably what you're going to stick with, unless you just can't do that well, in which case you might make an intubation attempt. MJ, I don't know if you saw that posting about starting up a degree program in Namibia this morning.
I did, from Blair?
Yeah, my wife just said no to going to Namibia. So
It's a beautiful.
I hear it's beautiful there. Yeah, I would love to spend a couple of years in Africa. That would be just amazing. Anyway, great opportunity. For those of you who didn't hear about it, there's Blair Bingham is looking to help the Namibian government set up a 4-year degree program for paramedics and set up a medical school and some other things. And so they're probably going to be looking for paramedic educators, presumably at the ACP or CCP level, to help out there. Sounds very exciting. But, my wife said no when I wanted to become a prof in Australia, so I didn't think she'd say yes to Namibia either. Oh yeah, Chris, so lots of countries have degrees now, right? Like Australia, the UK, New Zealand, Poland, a number of countries in the Middle East have degree programs for paramedics. That's interesting, eh? The official language is English in Namibia. That's cool. I didn't know that. A lot of African countries, it's French. Some places, Portuguese, Spanish.
I think it's because of the proximity to South Africa.
Right.
They're bordering countries.
Yeah, makes sense. Makes sense. Okay, so moving on here. Supportive care again. So control external bleeding, suspect internal bleeding if there's any hint, like abdo pain, chest tenderness, pelvic pain, not necessarily pelvic instability. Establish IV access PRN, IV fluids medication as per directives, and patch early for fluid resuscitation if you've got a kid who's showing signs of compensatory shock. So they're tachycardic, they're normal tensive, and they're pale or they're cool or showing a sympathetic response. Patch early for fluids would be my advice. And try to prevent hypothermia in these kids with a warm blanket, a heated ambulance. Fluid resuscitation will drop their temperature very quickly. 20 cc's per kilo could drop their temperature down from 36.5 to 35 quite easily. A little bit more fluid than that, they'll be down to 34 in no time at all. So keep that in mind. Any questions about pediatric trauma?
Less a question, but more a statement in that the new directive coming up will allow us to treat these traumas with pain management.
Yeah, which is great. It's a nice positive step forward.
You just have to be older than 1 year of age.
Mm-hmm.
Yeah. And I mean, for kids, you don't have to worry about the chest trauma, abdo trauma, like in the previous directive.
Yeah, it's just pain. I know they simplified it, which is nice. Yeah. So, good story. You have to patch to confirm the dosage.